Hello, and welcome back to the ASCO Journal of Oncology Practice podcast. This is Dr. Nate Pinnell, medical oncologist at the Cleveland Clinic and consultant editor for the journal. Like many academic oncologists, I have to attend on the inpatient hem-onc service 2 or 3 times a year with a team of internal medicine house staff, and usually a fellow. I know I'm always looking out for residents who are interested in oncology, but I'm wondering if maybe I should be paying a little bit more attention to the kind of experience they're having on their service. I was very interested to see a paper published ahead of print in the JOP this month called Inpatient Hematology-Oncology Rotation is Associated with a Decreased Interest in Pursuing an Oncology Career Among Internal Medicine Residents by Drs. McFarland, Holland, and Holcomb. Joining me today on this podcast is Dr. Tony Bach to discuss his commentary on this study titled, What Residents Learn from Inpatient Hematology-Oncology, a Call to Rebuild a Community of Practice, which is scheduled to be published in the JOP in July 2015. Dr. Bach is a professor of oncology and an adjunct associate professor of medical history and ethics at the University of Washington School of Medicine. He specializes in GI malignancies and is also an expert in communication between physicians and patients. Dr. Bach, thanks for joining me today.
Thanks, Nate. It's nice to meet you.
Nice to meet you as well. So I think that the title of the McFarland paper is relatively self-explanatory, but before we delve into your commentary, would you mind briefly summarizing the study's findings?
Sure. What Dr. McFarland and his colleagues did was do a single-site study that involved before and after measurements of internal medicine residents who are rotating on a busy inpatient oncology service. And what they found was that looking at the post measurements versus the pre-measurements, that internal medicine residents had less empathy, they were more burned out, and they were less interested in having a career in oncology at the end of the rotation than at the beginning. And it's a pretty sobering study.
Yeah, I agree. And now, when I read the results and the discussion in the paper, they sounded almost surprised at these findings. But I have to admit, when I read your commentary, I had a similar feeling that you commented that you found their findings depressingly familiar. What resonated with you about this finding?
Yeah, so when I'm inpatient attending on our oncology service, I feel like there are always a couple of residents who are really interested in oncology and they're really trying to figure it all out. And then there is a larger group of residents who are just trying to get through the month. They feel like the service is full of patients who have impossibly complex, rare, weird problems that aren't really going to help translate, into a better career for them. And they feel like they don't have much control or say in what's going on. And so they feel a little disaffected, maybe more than a little disaffected. And, as the attending, it's hard to engage them.
And so looking just kind of at a general inpatient setting, what do you think contributes to some of this decreased interest and empathy that goes on throughout the rotation?
Yeah, well, the big thing that I see and that one of my co-authors pointed out to me, and she was the past chief resident here who was actually going to have a career in medical oncology. What she pointed to and what I also see is this. Most of the patients have an outpatient oncologist who really calls the shots, who is really the one they trust, who's really the one that's determining their plan of care. Patients are looking to that person for decision-making, especially because, most of the solid tumor patients who are in the hospital, they're in because of some unexpected problem and some crisis, some complication. And so they're really looking beyond the team, and I think the team can find that pretty frustrating.
Well, that certainly makes sense, although to play devil's advocate, we spend years sometimes building relationships with these patients, and then when they're admitted to the hospital, they're having to be cared for by people who are just meeting them for the first time. And when there are difficult situations that come up, it's certainly understandable that the outpatient oncologist would want to have some input in that.
Yeah, I think it's hard for them to get to have a meaningful role because the patients are often in the hospital for a very short period of time. the inpatient attending frequently defers to the outpatient attending. And what that means is that there's just not much involvement of the inpatient residents in the decision-making that goes on. So they don't really hear much about what's happening in the thinking of the outpatient oncologist. They don't hear a lot of the conversations between the inpatient attending and the outpatient attending. And so they miss out on all the nuances of the decision making and all the discussions that often happen about, what's the patient's prognosis, what is their situation, how much more anti-cancer treatment is there. And then they feel like they're just, making discharge appointments and making follow-ups. The most involvement that they have in decision making often is, just making the appointments with the outpatient oncologist after discharge, and that doesn't feel very meaningful to them. So they end up feeling like they're just there to write orders for the inpatient attending and the outpatient attending. Thus the self-described order monkey label, which actually I hadn't heard until the last time I was attending. And, it's pretty cynical.
I can visualize, certainly there are patients that would apply to. I think the subset of patients who are clearly nearing the end of life during the admission, it sounds like that would be, I can visualize and understand this being an issue. In my experience, the majority of patients who are admitted are typically admitted with some sort of a general medicine problem. They have pneumonia, they have a clot, they have a fracture, they have some pain, things that I hope that the residents are able to take some charge of and to manage. But do you think it's the ones that really do have a meaningful kind of life decision during that stay that are the ones that are driving this dissatisfaction?
Yeah, I do. I mean, so I totally agree with you. Someone gets admitted with a pulmonary embolus, that's certainly something that a internal medicine resident can have a big role in working up, starting treatment on, et cetera. And I think they feel good about those cases. I think the ones that stick in their minds, and I think there is kind of a cognitive bias about these cases, are the end-of-life cases, and especially the cases where the resident feels like, wow, this really looks bad, and what they are told by the inpatient and outpatient attending is, you can't really talk about this with this patient, you have to leave it to me. Or they hear, this patient's not ready. Or they hear, you know what, we're just about to put this patient on a trial. And this idea that you're not really supposed to talk about the big picture with your patient who is really sick, that is what I think really sticks in their throats.
No, I can definitely see that. And if we look at the role of the attending physicians, I certainly can relate to your comments on how we as attendings may contribute to this. I know that I certainly feel stressed out when I'm on service, and I know many people are always concerned about their day jobs don't go away when they're forced to attend on the inpatient service. So, what are things that we're doing wrong as attendings that it's contributing to this?
Well, yeah, it's not even that I think we're doing things wrong. I think it just reflects, the structure of these services as it is now. When I'm inpatient attending, all my other responsibilities to do research, to deal with my outpatients, those keep going. And on top of that, I have this other big responsibility for this group of inpatients who are, really sick. So, since I'm at an academic institution too, and care in a day-to-day way for a very limited number of diagnoses, all the patients who come in with other diagnoses, those are things I need to rely on my colleagues for, need to look up, don't feel quite as confident in just kind of day-to-day management, or don't feel like I have as good of a feel for where they are in their cancer. And so this is where, there is no alternative but for me to rely on, their main doctor. And for me to somehow try to bridge the gap between that doctor and the inpatient team. So what I think the residents are pointing to here is a kind of discontinuity in the system. that really affects how they see the practice of oncology. And that's what really worries me, and the reason I wrote the commentary.
And you had some very interesting ideas about how we can potentially make this a better system for them. So you mentioned something called a community of practice. Can you tell me a little bit about that concept?
Yeah, the idea of a community of practice is that in areas of human culture where there's a very specialized kind of expertise, people have often banded together in what's called a community of practice, which is a process of collective learning that is considered a shared endeavor. The anthropological example is, a tribe learning to survive, a group of engineers working on a similar kind of problem, a band of artists who are experimenting with a new thing. And I think there's a way in which oncology units, inpatient units, are communities of practice. We are a group of clinicians who is learning to take care of this rapidly changing group of people who are living with cancer. They're living longer, they're getting new complications, they're getting, rafts of new treatments that are coming out all the time. And so I think there's a way in which the inpatient unit ought to be considered as much a learning collective as it is considered, a place to go when, the situation has kind of blown up. And I feel like that would give us a different stance towards how we construct the clinical experience, both for ourselves and for the residents who are there. Because, it turns out burnout is turning into a huge issue in oncology. And I think it's not just for the residents, it's for the attendings too. And I think, this process of breaking down every clinical interaction to the smallest unit, even though that helps us with efficiency and helps us with the design of certain parts of the hospital, it actually puts us at a distance from what's happening to people as they live with cancer or go through a successive number of treatments, and, in many cases live longer than ever before. So that's a way in which I think we could usefully reorient the way that we think about inpatient care.
In many ways, what you describe sounds like what we already sort of think an inpatient team should be like, but sounds, all of our experiences are the ideal gets pushed aside for the practical sometimes. So can you give me examples? How would you apply your community of practice idea to a more ideal inpatient service, and how that would differ from the way it is now?
Sure. I think that one of the things about how the inpatient services are constructed now is that many of them are constructed with attendings who have a really pivotal role, who have a pretty short amount of involvement during the year with the service. So they come in, if I'm doing a couple of 2-week stints on the service in a year, that means the first week I'm there, I'm kind of just figuring out what's happening to the service. And I wonder if that is actually the best structure for inpatient care. What it means is that the inpatient attendings are constantly relearning the service, that there isn't this sense of knowing how things go so that you can start to really enhance the camaraderie, the amount of learning, the innovation in terms of how the inpatient service works. It's really that everyone is scrambling just to figure out how to make the right things happen. And I wonder about that. In other studies, predictors of faculty vitality in academic settings are about the quality of relationships they have with colleagues and trainees, and about the alignment of their personal values with the institutional values. And I think one of the things that our current structure is setting us up for is, you don't know everybody very well on the inpatient floor commonly now. And your values as an oncologist get kind of lost in just the throughput of trying to get everything done every day. And so I wonder about restructuring services to make them more stable in terms of attending. That would require a big restructuring of jobs, but it would also enable the inpatient units to be more cohesive teams, which I feel like is one of the things this study is warning us about.
Yeah, I wonder if they had done this same study at a place where they use a hospitalist, for example. I know a lot of services use that model where they just have a few attendings who take care of their patients year-round rather than rotating through a couple of weeks or 4 weeks a year. If that might have changed the results somewhat.
Yeah, you do wonder about that. I mean, I think that's a really interesting question, and certainly something that deserves some other study. The other example I mentioned in the paper is an interesting experiment is what is happening at Duke with an inpatient oncology service where there are two attendings, and there's one attending that's an oncology attending, one attending that's a palliative care attending. The idea of the palliative care attending is that many of the issues that are really relevant for internal medicine residents do revolve around supportive care issues. And things that aren't, strictly speaking, anti-cancer treatment, like the pulmonary embolus that you mentioned. And because the palliative care people focus on, how do you make sure the communication is happening between everybody, it is by their measurements and anecdotal experience that I hear, definitely changed the experience for residents on that service. And so I think that might be another model of ways to shift the balance on inpatient services. So there is one other sort of cancers-related thing that I wanted to mention is that I think there is a role for faculty development for oncology attendings who attend on these services about, what is in it for internal medicine residents? Because I think without too much retooling, most oncology faculty could make sure that they relate the weird case to the common case, right? That they relate the outpatient care to the inpatient care and connect the dots for the residents more clearly so that the residents can start to see the outpatient admission as a kind of outlier that connects to a larger story that a patient has about living with their cancer. And, little bits of that could come up on rounds in ways that would help residents see, the total picture and what this particular episode means. And I think that would help them too. And I think that's a different way of thinking about, our role as educators while we're inpatient attendings.
You make some practical recommendations at the end of your commentary about how we can better change the inpatient experience. I know you've mentioned some of these throughout our conversation, but just to kind of summarize that, would you mind taking us through those?
Sure. And of course, there's not that much study about how to restructure these because I think this is a problem that's just coming to light. But, I've mentioned these in our podcast already, the idea of faculty development that will enable oncology attendings to both connect the dots between inpatient and outpatient care and model a kind of constructive mediation between the outpatient oncologist who isn't at the bedside and the inpatient resident team who feels, often overwhelmed by how sick people are. I think restructuring the rotation to be more like a learning environment, that might mean having a different kind of attending who's there in a more stable way. I mentioned the other experiment at Duke of having the inpatient rotation contain a oncology attending and a palliative care attending. And then the last thing I mentioned in the commentary that I think is that we haven't talked about yet is that for academic oncologists, there is this whole set of skills that don't get addressed very clearly in fellowship that are really critical to success. And they have to do with leadership in terms of leadership of the team, mentorship in terms of how they deal with trainees, the ability to think in a system and think about a system, and the ability to be resilient themselves. And I think that skill set is really important, and that in a secondary way, this study is pointing towards. So it's a pretty big agenda that I'm talking about here. But I do think this is one of those things where it's about all of us starting to think about how to improve things and doing a bunch of small experiments to see what really works.
I hope that our listeners are in a position to do something about this, and hopefully we can make this a better process. So Dr. Bach, thank you so much for joining me today.
Oh, thanks for having me and your interest in the article.
And thank all of the listeners out there who joined us for this podcast. The full text of this paper will be available at jop.ascopubs.org in the July 2015 issue. Don't forget that you can also read the JOP and access these podcasts on your smartphone or tablet with the ASCO Journals mobile app, available in the iTunes Store and Google Play. This is Dr. Nate Pinnell for the Journal of Oncology Practice, signing off. Thanks for listening.